This guy spoke at it, and he was describing, I think might have just been papaverine. And so he injected himself at the podium.
Before we dive in, it's important to remember that the information we provide is for informational purposes only. Every situation is unique, and decisions regarding your health or legal matters should be made after consulting with your own doctor or lawyer. Our aim is to inform and empower, but personal circumstances require personalized advice. Hi, welcome to another edition of Justice in Scrubs. I'm attorney Richard Hastings, and I'm joined by my co-host,
Dr. Jeff Michaelis.
And today we are joined by a very special guest, Dr. Bill Hennessy. Welcome
Hello.
to the show.
Nice to be here.
So why don't we start off by, you're a urologist.
I am.
And
Or was
a urologist.
Retired.
What does a urologist do? What do they deal with? And what are like the most common things that someone would come to see you for?
So we handle disorders of the urinary tract in men and women. So that would be kidneys, the tubes from the kidneys to the bladder called ureters, and then the bladder, and then the passage from the bladder to the outside, which is the urethra, which in a man is much longer than a woman, and in a man right below the bladder, it is surrounded by the prostate, which is an organ that is essential for fertility. It makes chemicals and enzymes that support fertility. We also handle other disorders of male genitalia. The prostate would be considered part of the male genitalia. We also care testicles, abnormalities of the penis. In children, we deal a lot with pediatric hernias and undescended testicles, things of that nature. So we do a lot of surgery, kidney tumors, bladder tumors. We also deal with medical issues related to the urinary tract. Most commonly, probably infections in men, women, and children. And of course, we do deal with abnormalities of urinary function. Most people think of a urologist as someone who just takes care of prostate problems. Men have difficulty urinating. They urinate too little, they urinate too much, they can't empty the bladder. Women urinate too often, frequent urination is a bother. Urinary infections in women are common things that we treat. In women, we also treat problems holding urine. A lot of women have abnormalities called incontinence, which is usually in a woman something called stress incontinence, which means when they cough, sneeze, move suddenly, lift something heavy, they may spurt some urine because over time after childbirth, but there are women who've never had a child who will also experience stress incontinence, and the muscles kind of relax and just don't support the bladder as well as they did and allow a little leakage. And of course in men, a common thing that we deal with is erectile dysfunction. Difficulty getting and maintaining an erection, which has a myriad of causes and a myriad of treatments depending on the severity and the bother.
So why don't we'll start to break these down and go
Sure.
through the probably most common reasons why a man or a woman would come and visit with you.
Right.
So you touched briefly on ED or erectile dysfunction.
Sure.
So why don't you kind of give us the lay of the land on ED and, what's the average age, what percentage of men, what are the causes, what are the solutions?
And it's funny, the average age, because I'd say more and more younger men are coming in with complaints of erectile dysfunction, I think almost because of performance anxiety. They're afraid they're not functioning well. But I'd say, first of all, there are a variety of causes. One cause, a very common cause, especially in the younger population, is anxiety. Performance anxiety, they're just worried that they're not performing as well as they should. But as you get older and you get more organic causes of impotence rather than psychogenic causes of impotence. And we kind of deal with impotence as a symptom as well as an illness itself, because there are some serious things that contribute to the development of erectile dysfunction: cardiovascular disease, diabetes, hormonal abnormalities, hypertension. Anything that can affect the blood vessels can affect your ability to get and maintain an erection. And so when we see somebody who's complaining about ED, the first thing we do is do a pretty thorough history and physical exam. The physical exam is often not terribly informative because there are no overt physical manifestations of erectile dysfunction. There are some things that cause erectile dysfunction that are also very physically obvious, a few anyway. One of them is something that I see advertised medication for often on TV, Peyronie's disease, which is let's say a scar tissue that forms on the dense covering under the skin of the penis, and it can fibrose and cause curvature with erections, and one severe can actually cause the inability to get an erection. But other than that, there aren't that many overt physical signs. So you will do an exam, check the pulses. If he doesn't have good groin pulses, then you can say, well, maybe this guy's not getting enough blood supply to his penis to create an erection. His history, okay, well, he had a radical prostatectomy. And although we like to think that none of our patients that we operate on for prostate cancer develop erectile dysfunction, probably in the old days, a good half, maybe it's still a half, maybe it's more, but I think with the robotic procedures that are being done now, it may actually be less. So you take a history. Very often they've had blood work done by their family physicians, so you don't really need to do a whole lot of blood work. But certainly you want, hey, are they diabetic? Did anybody screen for that? And check their testosterone. Are they hypothyroid? Most people would have been diagnosed by the time they hit us, but and everybody's doing testosterone levels, because everybody who is a little sluggish and doesn't do anything as well as he used to feels he must have testosterone androgen deficiency, and most often they don't, but sometimes they do. So that's something worth checking for.
So can I just ask you?
Yeah.
So for a man to get an erection, what part does blood flow cause, and what part does testosterone play, and what does testosterone do to a male to get an erection? Okay,
testosterone, of course, is the fuel that sort of helps us function as men. Your hair, your mindset, and also it does have an effect on the smooth muscles in the penis. And so if your testosterone is low, then indeed, in addition to maybe not having that much of an interest, because of its need to support the health of the tissues in and around the penis, it has an effect on your ability to get an erection. Everything is blood flow, and testosterone helps support blood flow. And certainly somebody with bad vascular disease, if you have erectile dysfunction, you're at some risk for heart disease, coronary disease, because we're talking about small bore blood vessels in the heart and in the pelvis going to the penis. So it's not unlikely or unusual for a man with heart disease also to have erectile dysfunction. And as I say, if somebody presents with erectile dysfunction and they fit other, age criteria, then indeed you want to make sure they've been screened for cardiovascular disease, just with an EKG and a history.
So let's talk about lifestyle changes that a person could make to perhaps ease or reduce the risk of ED.
Okay, it's anything that's good for your heart is good for your penis and your prostate. So
Sounds like a tagline.
I don't think it's original with me. I think I heard that somewhere. So certainly, diet, exercise, moderate use of alcohol. These are all good things. So,
Not smoking.
Oh, smoking is a deal killer. Okay, because smoking constricts the small. It's funny. I don't even think about smoking anymore because so few people that we've seen that I saw in my last few years in practice, really smoked. Fortunately, it's not a big deal. Although I'm not sure if it's increasing again in the those in their 20s and 30s. But sure, smoking is a deal killer in so many ways. But that's basically it. And one thing that's interesting is that if one wanted to be really hard about it, if I went into a doctor's office and I said, I'm having difficulty with my erections, can you give me a medicine or do I need an operation? He'd say, no, you need to lose 30 pounds because adipose is a testosterone sponge. You can, if a guy who is overweight, especially seriously overweight, he has enough testosterone, he's producing enough testosterone, but it's getting sucked into his adipose and his fat. And so losing weight, I have a family member who thought he might be having issues, and he went to see his doctor, and the doctor sent him to see an endocrinologist, and the endocrinologist said, you don't need medication. His testosterone was slightly low. You need to lose weight and exercise more, and you'll do fine. And again, other lifestyle things that aren't always in your control would be reduction in stress. But more guys get stressed out about ED, and then it becomes a vicious cycle.
So losing weight alone could help a lot.
Absolutely.
It's funny. We had a separate episode where we talked about 4 of the 5 leading causes of death in this country. Accidents was one of them, so we take that out. But out of the remaining 4, every one of them had lifestyle issues like being overweight, smoking, excessive drinking, being sedentary, not exercising enough.
Absolutely.
So like you said, I mean, the heart drives everything.
The penis drives everything.
It's been said that more men do their thinking with their little head than with their big head. It certainly can rule you in ways that may not be very good for anybody. Again, it's been said about so many things, but if it's good for your heart, it's good for everything else you got going for you.
So we talked about some lifestyle changes that we could make. So I guess the next option would be for meds. And what meds are there, and what do the meds do?
Okay, so the medication by and large are what we call vasodilators. They tend to relax the smooth muscle, the muscles around the blood vessels, and you relax the blood vessels, and that just allows more blood to flow. And so the big ones are drugs like Viagra was the first. Then there was Cialis, Levitra, Stendra. There are a few others. These are oral medications. Viagra was the first one to come out, and Pfizer did a very bad thing to urologists. They put it out in the air, on the airwaves, and they put it up for prescription before they ever really detailed the urologist about it. So we had patients calling to get prescriptions about a drug that we hadn't really been educated about. And it caused a lot of headache. There was this one very nice Pfizer detail woman who was coming to our office at the time. And I said, you owe us big, the amount of work that we've had to do to learn, and why didn't you let us know about it first? And so I actually got her to buy the full edition of Campbell's Urology, which is our Bible in urology. And so she bought one for each of us, and we thank her for that. So you want tickets somewhere? I said, no, educate us. buy us Campbell's, and she did. And then Viagra was the first. It has, I can't remember now I think it's like an hour or two before you tended to need it that you had to take it. And then the others that came after were either quicker onset, longer duration of action. Cialis was the weekend pill. You could take it on Friday and be good to Monday. and then in addition, now when they don't work, when the oral medications don't work, then you move up to there's an injectable. And it's a combination of drugs, including papaverine and prostaglandin E1, each of which is a vasodilator of sort. And these you would be taught how to inject into your penis. And
Wow.
diabetics do this on a daily basis, so it's not a big deal once you know how to do it.
I guess it's the first time doing it. That's the big deal.
So you teach them, and you watch them do it, and you say, you sign off on it. And it's rapidly acting. And it's not likely to result in a problem called priapism. Priapism is a not erotically associated erection, painful, doesn't go away, requires manipulation, actually irrigation in the emergency room to bring the erection down.
Oh my God!
And it's not common, not unheard of. Risk factors are sickle cell disease, so you see it in a lot of African American men, and also leukemia. It's been a form fruste, is that the right term?
Yes.
Of leukemia. Somebody goes in with priapism, they find out that he has leukemia. So, but that's really uncommon.
So
that's a board question, actually.
So if you use the injectable,
Yeah.
you, for some short period of time before you're to engage in a sexual act, you physically inject yourself in your penis.
You could excuse yourself and go and tell your partner that you're going to take a leak and come back at full attention. So some men will test dose themselves and they won't get a good erection because they're not being, they need some sexual stimulation. If I might digress, I think this is okay for prime time. When the first guy to get the concept of using injectables for erections was a psychiatrist, and the American Urologic Association is our national worldwide organization, and they have an annual meeting once a year. Urologists from all over the country and the world come, and this guy spoke at it, and he was describing, I think might have just been papaverine, and so he injected himself at the podium. He's a psychiatrist. He injected himself at the podium and walked through the audience showing the result. And then
Was he proud?
he was alert. So then there was a meeting at which, I forget the urologist's name in Manhattan. He told a story about and so very often we would give a test dose in the office and say, now you got to get home. This is going to last about an hour, and try to have intercourse. See how good it gets, how good your erection is. Great. So he doses the guy the test dose. The guy figures he has about an hour. Wife is waiting at home, gets stuck in traffic, midtown traffic. His wife has to leave. He gets home, she's gone. He calls the urologist and says, my wife had to leave. What am I supposed to do? And he says, try it out on the maid. And the guy says, well, I've never had a problem with her.
That's a good one.
And it's true. They say it's true. I'll leave it. It probably is. And so, yeah. So the injectables are the next. I keep hearing about a formulation that is topical, that you would really just be able to rub on the skin of the penis and it would be absorbed, kind of like a nitro patch concept. and that could also stimulate an erection. Once you get beyond, if you dose somebody with one of the medications like Edex or Caverject, and they don't respond, then they've got that's diagnostic of organic impotence. It's not psychogenic. This guy has severe impotence of whatever cause. And that's when they become a candidate for the insertion of a penile prosthesis.
We wanted to take a quick break to remind you about our sponsor, findagreatattorney.com. Dealing with the aftermath of an accident or injury can be overwhelming. And the last thing you want to worry about is finding the right lawyer. Findagreatattorney.com simplifies the process by connecting you with one of the top attorneys in your area who specializes in your specific type of case. Whether you've been injured in a car accident, suffered a slip and fall, or experienced medical malpractice, Findagreatattorney.com has a network of experienced lawyers ready to help. And remember, their service is completely free, so you can focus on your recovery without worrying about the cost of legal representation. If you or someone you know needs legal assistance, don't hesitate to visit findagreatattorney.com and let them match you with one of the best lawyers in your area for your needs.
Penile prosthetics have been around, I'm going to say, over 50, or about 50 years. No, over 50 years.
Wow.
And they have made vast improvements in the equipment, the mechanics of it. They fail very infrequently. They're much simpler to put in.
And what is it?
Okay, so there are a couple of different varieties. The simplest one, going back to, again, probably the early 70s, was called a rigid penile prosthesis. And the developers were two urologists, and it's called the small carrion prosthesis. And somebody said, got to come up with a better name. It sounds like a small piece of dead meat. and so they've developed, these were rigid. They would be implanted with a little incision in the penis, and they are these spongy structures that engorge with blood to get an erection. And it's surrounded by a very dense elastic tissue that keeps the erection from just ballooning, okay? And so you can sort of hollow out the spongy tissue and insert a penile prosthesis. The rigid ones were too obvious. They were very hard to conceal. Then they came out with flexible ones, kind of like a drinking straw that would bend down. They weren't too bad, and those are still used. Not the rigid one, but the flexible one is still used. And then they developed a multi-component, basically hydraulic penile prosthesis. There's a bulb that has maybe about 3 ounces of saline in it that you make. It can be put in a variety of ways, but what they do is that they put this bulb filled with fluid into the pelvis under the abdominal muscles, which can actually be done through the groin, where you would show that you had a hernia, where a hernia would develop. You can poke it in there. And then it is connected to a pump, which is in the scrotum, and then the pump connects it to 2 cylinders that are placed in either side of what we call the corporal bodies of the penis, and it creates a very natural erection. And one of my professors, when I was a resident, was actually doing these. He figured out a way to put it in with no visible scar by making an incision in the scrotum. He can do all this work, and it's all routinely done now through a little scrotal incision. At one time, it was done through an incision from the belly button down to the pubic bone, and then side to side, all different modifications. But now they're put in with a little what we call penoscrotal erection, and nobody's the wiser. Like if you're estranged from your partner, you have no relations, maybe not even sleeping together, then they'd never know it. Okay, and this guy in Philadelphia, my professor, actually did have a number of men who came from out of town to get a penile prosthesis put in. But
and then do you have to do anything to pump it up, or it does it on its own?
There's a pump in the scrotum, and you pump the pump, and it transfers the fluid from the cylinder, from the reservoir to the cylinders, and then there's a deflate button.
So is there like a remote control you have?
No, it's an actual physical pump that's put in one side of the scrotum next to your testicle, above or next to the testicle.
The things we do for love.
The things we do for love. And, but again, sort of the pseudoscientist in me just finds the engineering of these things, the development of these things to be phenomenal.
Right.
And the fact that they're so reliable once they're implanted. Now, there can be problems. Cylinders can erode through the skin, and you have to take them out, and they can get infected. But by and large, it's a very useful and successful operation. This guy comes in to a urologist's office. Yeah. Urologist walks in, and the guy has this iguana on the table. And he says, "Doctor, I don't know what it is. My iguana is molting. He's losing weight." And the guy said, wait a minute. I'm a urologist. I'm not a veterinarian. He says, "Yes, you take care of erectile dysfunction, don't you?"
Okay, I got a story I got to tell you.
This is the one that you weren't going to tell?
Yes.
Oh, okay.
Okay, so when Viagra first came out, like 20 years ago or
Oh,
something?
no, I'm going to...
We'll say a long time ago.
30 years ago.
30 years ago.
Easily 30 years ago.
So my patient was 92 years old.
Right.
And he was celebrating his 70th wedding anniversary.
Good for him.
So he comes in, he says, "Doc, I need some of those blue pills because, I want to take care of my wife after, for my anniversary." So I give him the pills. A week later, his wife comes in the office. And he says, "Doc, never, ever give him those pills again. I've had my legs up in the air for 50, 60 years. I don't want to do it anymore. He was chasing me around the house. Don't give him any more of those pills." So after that, I always made sure that the partner is okay with that.
Right. I'll tell you another true story.
Please.
How history is necessary above all else. So this guy comes in to his urologist, an older gentleman, maybe actually my age now, but and he's telling the doctor that he's just not getting, he's not able to perform. His wife is still very interested, and I like to have treatment, and the guy says, "Okay, we can do this." Comes back with his wife a few weeks later, and she says, "Doc, he does just fine. He's got a little Alzheimer's and he just doesn't remember."
All right, since we're telling...
So it's interesting to see the partner's perspective
yes,
also.
Definitely. And I have to tell you, we aren't always that conscientious about interviewing the partner as well.
Right.
Sometimes because the guy has, like the guy who went home and the wife wasn't.
Yeah.
They had no intention of sharing it with her, so to speak.
Okay. Go ahead.
I was just going to say, since we're all telling inappropriate stories, and this is a true story, I was playing golf with my father and a friend of his, and we're on the tee box getting ready to tee off, and he said, "As I'm getting older, I'm getting stronger." And I said, "What do you mean?" He said, "I can bend my erection now."
I wish I was still practicing. I would definitely use that one.
That's a good story.
It's a good story. It's a very good story.
Okay, enough about that. So let's get on to the next thing.
Okay, so another thing that men complain about
Right.
a lot is peeing all night, waking up in the middle of the night to pee.
Right.
So you want to talk about that?
Yeah. Okay. So, right. Guys tend to complain about not peeing enough or peeing too much. And women, it's usually peeing too often and not being able to control it. But with the guys, more often than not, the cause is prostate related, but not always. So especially when it comes to getting up at night to urinate. there is a recognized entity, Nocturnal Diuresis, which means that you make more urine at night after, I'm not even sure if it's at a certain age, but you make more urine at night often than you do during the day.
Wow.
And some of it is kind of physical, mechanical. Somebody who has maybe a little twinge of heart failure, or anybody who develops what we call dependent edema, lower leg edema, when they go to bed and their legs are up, that fluid gets back into the system and they're going to pee it out. Man or woman, you're going to get up and you're going to urinate. But independent of that, there is also a nighttime diuresis where your bladder just fills up more rapidly at night. You make more urine at night. So that's kind of hard to deal with, although we have in some cases a severe. Some guys can get up 2 or 3 times a night, fall right back to sleep, no problem. Other guys, they're just besides themselves, and some guys get up almost hourly to pee. And the key is, are you peeing a lot or a little? And it's relative. And so I'm going a good amount. I'm going, okay, you're probably having a nocturnal diuresis. What can I do about it? Limiting fluids after dinner might help. But there's no official medicine that I'm aware of, although one may have come out in the past year or two that I'm not aware of. But there is a medication called DDAVP, or desmopressin, or antidiuretic hormone. Okay, and we have been using it forever in children with bedwetting. Because if you can just increase their bladder capacity a little, they may get through the night without wetting. But we would use it off-label sometimes for guys who had this unremitting, disabling nighttime diuresis. The other reason people will urinate more is if they're just not emptying. And so once again, you take a history, you do an exam, and ironically, fewer and fewer When was the last time you did a prostate exam on a patient before you retired?
About 5 or 6 years before.
Right.
A long time ago.
We make rounds, we do a consult in the hospital, and we're looking at the admitting history and physical, and without a doubt, when it gets down to prostate or rectal exam, deferred. To who they didn't say, but they defer it. And so we always felt, it was an important thing, we should definitely examine the prostate. And so I was at a meeting a year and a half ago. Very few urologists, younger urologists especially, are examining the prostate.
Really?
If you come in complaining, I have to urinate a lot, or they'll see how big is your prostate. But more often, for screening, they're doing PSA, prostate-specific antigen blood test, which is a screening test to assess risk for prostate cancer, and an ultrasound. And so what happens now, the guy comes in complaining about problems urinating. Almost every urologist has a little ultrasound machine in his office. The simplest one just measures the amount of urine in the bladder. It doesn't really create a picture. But most of us also had one where we could actually image the prostate, see how big it was. And if you're not emptying, then, well, maybe we can help you empty your bladder. Okay, and that's where another group of medicines come into play that shrink the prostate. The first one was Proscar. That shrank the prostate. I forget if there was one before or after Proscar that also shrank. And then there was, that didn't really work all that well. And they then came out with a group of medicines that, once again, relax the muscles in and around the prostate. 5-alpha reductase inhibitors. Yeah. And they relax the prostate. They work much better. Sometimes, and there is a medicine that combines the two. But you can have a very big prostate, and when you really, we always pride ourselves on doing these great prostate operations. The one that I was doing most of was a transurethral resection. Oh, I did a great operation. You do an ultrasound, and you realize that you just trimmed out a tiny portion of the prostate. It did the job, but there's a whole lot of prostate that you didn't touch. And so then they started realizing, well, maybe you don't have to take out the whole prostate like that. And that's when the newest treatment for enlarged prostate problems urinating is basically through a cystoscope, which is a little telescope that we can put into the prostate. You just tack the prostate tissue that's impinging on the urethra, and you just literally tack it to the side.
Really?
In usually 4 different spots. And that opens up a channel that, and you can see this visually, through the telescope. You can't see into the bladder when you finish, and then you can see into the bladder. You haven't taken anything out. It's an office procedure, and it works very well. Like everything, it has failures, and you sometimes have to redo it. And then the other thing that I just read about, it doesn't even have a CPT code yet.
Wow.
Okay, that's how new it is. Remember Chinese, does anybody remember Chinese handcuffs?
Oh, sure.
Okay. Well, it's kind of like, sort of like a Chinese handcuff, or a venous filter, a vena cava filter. You deploy this thing, and it expands, and it opens the channel. There have been such things for years. One problem with them is that once you put them in, they were very difficult to take out.
Did you put a stent in too, or you just open
This
it up?
cage, the cage
okay.
does it. It goes in through a transvenous catheter, but you just put it into the urethra, watching it with a cystoscope. Then you pull the sheath back, and this thing will expand and open the prostate. But you could take it out again. That's the benefit.
It's like they do it in the heart. They open up the arteries with they use
Oh,
a stent,
yeah.
or a cage, whatever you want to call it.
Yeah.
It's
Very
the same
similar.
thing.
Very similar.
I just want to circle back on something that
Yeah.
we had discussed before, and that is prostate cancer.
Oh, okay. Sure.
And PSA screening.
Correct.
And the importance of doing that on a yearly basis.
Yearly basis.
Because if you have prostate cancer and you have a PSA test, in all likelihood, it will determine that there is, or alert you to the fact that there's a problem.
Right. The whole idea behind PSA screening, which has at one point in time was pretty controversial. I think it's less controversial now, although there are still people who say you shouldn't do it. We, of course, think you should do it. So usually and the age keeps changing, but I'm just going to say between the ages of 55 to, let's say, 70, 75, the upper age keeps getting pushed back as people get healthier and healthier, or stay healthier and healthier, and have more time at risk to suffer the consequences of prostate cancer. So you get a baseline PSA. Anything below 4 is assumed to be normal, although if you're younger, maybe it isn't normal. So there are nuances, we'll say. Okay, but you get a baseline PSA, and then you follow it annually. And if your PSA rises rapidly, there's an acceptable increase with time of about like maybe 15%. Mm-hmm. But if it starts, going faster than that, or if you happen to be one of these people who still does a rectal exam and feels a nodule, then you say, well, maybe you deserve, a biopsy. I have to admit, I practiced for 35 years. I think I felt one nodule, really. Everything else was diagnosed on PSA screening. So, and then if your PSA goes up, then you would be advised to have a biopsy. And if your biopsy is negative, then you just continue being screened maybe every 6 months for a while, or go back to annually. And then if the biopsy is positive, then that gets into a lengthy discussion of treatment options, of which there are many. But I would say, since the advent of the robot, more and more are opting for surgery, because if the surgery, first of all, nothing beats taking out the diseased organ. Okay. The problem is the prostate is at a really kind of tough spot to take out without running the risk of leakage or impotence. But as I say, it does appear that the robot, what the robot does, it magnifies the field 10 times. So you can almost see the blood flowing through the vessels or the vein but it's and then the robot itself, the equipment is just, some people have an intention tremor. Doesn't matter. You don't have a tremor when you operate with the robot. It dampens, and you could actually do a robotic procedure. You could have the Mayo Clinic do your prostatectomy, you in Danbury, and they're in Minnesota. Now that they don't recommend doing that, but you could indeed do remote robotic surgery. It's not done, but theoretically it's possible.
So as our time is winding down, I wonder if we could just touch briefly on urinary tract infections.
Terrific.
Men get them, women get them. What are the causes?
Right.
What do you do?
So men get them less often, and it's a fairly simplistic theory of the cause. Most urinary tract infections are what we call ascending infections. They come from the outside. Bacteria come from the outside, and they migrate up the urethra and into the bladder and cause infection. Okay. So as a result, women are much more prone to lower urinary tract infections, so actually both. Cystitis is very common. We won't even try to quote a statistic, but usual symptoms are certainly burning on urination, frequent urination, and sometimes incontinence. Easily diagnosed. The standard was to do a urine culture, which required taking a specimen, putting it on a substance that would allow the bacteria to grow. If it grew, then they would put little discs of antibiotic impregnated wafers on the dish that was growing the bacteria and see which ones killed it. And this is something I will confess just a glancing familiarity to, because it's just been coming on board now. They can now do DNA testing to find out what the bacteria is, and I don't think it's. I think they even have one that can be done in the physician's office.
Wow.
And you can treat them based on the results of that. So the problem with urinary tract infections is if they go untreated, they can become upper urinary tract infections, which is the kidney infection, pyelonephritis instead of cystitis, which can be very serious. In men, they get infections less frequently. One reason is just the barrier or the distance the bacteria has to travel, and it doesn't go quickly enough, and when the guy pees, he may be able to pee the bacteria out. There also, the mucus in part of the urethra may be bactericidal or inhibiting it. It can actually kill the bacteria. And so the big problem with urinary tract infections in men is prostatitis, which many men think they have prostatitis because they have frequency and urgency of urination. But again, it's from some other cause, some other irritation, or again, could it be psychogenic? Sure. But a full-blown prostatitis can be a life-threatening illness, because it rapidly, both pyelonephritis and prostatitis can become systemic, bloodborne. You can get septic from it. And so you really want to jump on either of those if you think you're dealing with it. Treated early, it's very successfully treated. Both the kidneys and the prostate have a very rich blood supply, so it's easy to treat them if you make the diagnosis rapidly.
So as we're kind of wrapping things up now, what are the pieces of advice that you would give to the general population about staying in good urological health?
Like I say, cardiovascular health. And the other thing is, when you gotta go, you gotta go. Don't sit around for hours, with a full bladder, because, especially if you're a woman, because again, the bacteria get up there easily, but if you're urinating reasonably often, you're going to wash it out before it really, gets a foothold and makes you sick. Other than that, it really, there's no prostate exercise. I'm not a big believer in all the supplements you read about. I don't know how they get started and how they become, so common. But, there was an article that I got a glimpse of on, my Google feed on my phone, where they did do a study, and multivitamins, this is brand new, multivitamins, and it's not news, do nothing to prolong longevity.
What about Kegel exercises for women?
Okay, they will work. Okay, that's a point. And also we talk about Kegel exercises for men who've had a prostatectomy, who have annoying but not really severe dribbling. And the only problem with Kegel exercises is A, knowing how to do them right, and B, doing them, because they're so monotonous. And it's not like lifting weights where you can see what you're doing. Kegels, it's very hard to really know if you're doing them right. And the thing that you don't want to do is just squeeze your cheeks and constrict your butt and your rectum. You really have to try to, and it's very hard to really kind of visualize or contemplate, but you want to try to work on the forward. There's the forward muscles. There's a pelvic sling that the urethra and rectum go through to the outside, and it holds all the internal organs in. And you want to try to work on that sling. And with a guy, it's easier to teach him how to do it, because if you can teach the guy and try to, you can do this at home, but you just try to look down, and if you can kind of draw your penis in, which you can look down and see, and not feel your butt constricting, then you're doing your Kegels right. I don't know if, I'm sure a woman could kind of, conceptualize the same thing of rectum loose, anterior pelvic muscles, constricting. Now, there are monitors that you can put on to determine which muscle group you're working, and there are actually many urologists have a biofeedback practice too, where they have the women come in, or the men, and they put the EMG, the muscle monitors on, and try to localize the anterior muscles and try to teach them, okay, when you're doing this, you can hear it now, or you can even see it on a graph. And so that's not a really common thing, but it's definitely valid.
Yeah, we've sent them patients to physical therapists that specialize in that, and that was very helpful.
Yeah.
Because it's difficult to do a Kegel exercise properly.
Correct.
But if you get the advice of a physical therapist
Right.
that specializes in that can be very, very
Yeah, we have
helpful.
a nurse, I assume, I retired 8 years ago, my God.
Wow.
But we had nurses who would run our incontinence program. So yeah, definitely can work. Simple, but again, tedious.
Dr. Bill Hennessy, thank you very much for your time
It's been a
and all
pleasure.
this great information.
I hope we don't get censored for anything.
Well, if we do, we'll tell you.
Oh, thank you.
Great to see you again.
It's always nice being seen. As they say, better seen than viewed.